Okay, everybody, can you hear me? I'm hearing yeses, great. Hello, everybody, welcome to the panel. How are we doing today? Yay, okay, excellent. Today's panel is on emerging drug risks and harm reduction innovations. My name is Bryn, I'll be your moderator today. Hola a todos y bienvenidos al panel, me llamo Marin. A bit about me, I'm a harm reductionist and a case manager in homeless services and overdose prevention for the last 5 years, both in California and in Boston. Case management is very unique because you work directly with clients doing kind of arbitrary things sometimes. You give out Narcan and syringes, but you also do paperwork and yell at landlords together and things like that. So it's a very interesting, direct work. But what I will say is that it gives you real insight into the daily challenges and wins of those who are navigating broken systems as a drug user. We see how an unknown drug entering the drug supply can rack an entire community, and how a new effective empathetic innovation can really transform patient trust and connection. So I am so excited to learn from the incredible speakers we have today who are on the front lines, dedicating their careers to understanding new risks in the drug supply and finding new ways to help those we care about. Today, we are joined by Dr. Daniel Ciccarone, Dr. Kristin Schneider, Chris Rintoul, and Dr. Greg Rosen. They're each tackling urgent issues from tranq dope and xylazine injuries to nitazene overdose responses to overdose prevention technology. We'll hear from each of them and then do a short Q&A at the end. Okay, so first up is Dan. Hi, Dr. Daniel. Dan is a doctor of medicine specializing in family and addiction medicine and current professor at UCSF. Over the years, he's done extensive research on HIV/AIDS treatment and prevention among people who use drugs. He's served as principal or co-lead on numerous NIH-funded public health studies, is an editor for the International Journal of Drug Policy, and is widely published in medical and public health journals. Today, he's presenting his research on tranq dope, a combination of xylazine and fentanyl, and its link with severe skin injuries. Ready?
Hello. Hi, everyone. It's a real pleasure, real honor to be here. I love this conference. I love the energy, the feeling, the solidarity. So thank you all. And I know it's late in the day, so thank you for being here late in the day. There we go. So I'm going to talk about tranq burn. And I entered this because it's the answer as to what's causing tranq-related wounds is unknown, right? And I like puzzles, so I decided to sort of weigh in. Doesn't mean my answer is right. I'm just weighing in with my hypothesis. So I am a professor of family medicine, professor of addiction medicine at UCSF. I've been doing this for a long time. I've been a proud harm reductionist for over 25 years. It's great to see so many colleagues and friends from over the years. I was a medical director of a syringe service provider way back in the day. I was then on the board of directors of a different one. I've been involved. Currently, I'm proud to be the voluntary medical director of Remedy Alliance, the U.S.'s largest not-for-profit wholesale supplier of naloxone, last year distributing 2 million doses of the product. So I'm a biased player in the naloxone field. But I'm also a paid consultant for a private group called Solero Systems. We're working on an overdose detection and treatment device, medical device. So by tranq dope, I mean the combination of xylazine and fentanyl. When we talk about xylazine, almost always we're talking about xylazine in the context of fentanyl co-use. 90+% of deaths are co-occurring. So they're not xylazine deaths, they're xylazine and fentanyl-related deaths. We see here rising in these deaths of co-occurring fentanyl and xylazine deaths. It's very common in certain regions of the United States. So we're going to focus today on Philadelphia, which has sort of been the epicenter. We see Pennsylvania in purple here, but also that blue region is getting a lot of xylazine now. I was talking with Mona earlier from Atlanta. They're seeing xylazine. We're also seeing it on the West Coast, so it's spreading. Xylazine is an alpha-2 agonists. So let me break that down. So this is an agent that we use in medicine, not xylazine, but we use other chemicals in this class, like clonidine, to reduce blood pressure. And it's very good at doing that. In fact, it's a little bit too good. It's not a first-line agent. We also have used it in the past, not so much anymore, to help people go through a detox, go through a withdrawal from opioids. It's a useful medicine there. In fact, people also learned that if they added it to their opioid, that it potentiates it a little bit. So that might give a little clue as to why we're seeing it today in combination with strong opioids. But it does have its downsides. It's a very powerful sedative. It causes lower heart rate, bradycardia. It can cause very serious hypotension. And I think if I wasn't giving a talk today about wounds, I could be talking about renal failure from low blood pressure. When it's injected, there seems to be a strong relationship to the skin and soft tissue injuries. Mechanism is unknown. I would say the maybe growing majority are pointing to this idea that it's a vasoconstrictor. In order for it to lower blood pressure centrally, you've got to clamp up everything peripherally, right? And so that vasoconstriction is leading to low oxygenation and tissue death. There's going to be some graphic photos. The wounds become chronic. They cause a lot of suffering. Fortunately, they're not painful, at least not in the center. Maybe the edge might be a little bit painful. They're considered sort of similar to, or we can make them analogous to sort of third-degree burns, where there's so much damage that the nerves are not firing. They can last a long time. Even if somebody were to leave that area alone, it requires extensive nursing care to make a wound like that go away. So this is a mixed methods project. A lot of what I do is qualitative research, but I also would like to bring in some quantitative, so you're going to hear some laboratory results coming up as well. But this was a one-week immersion in Philadelphia. It's not our first time in Philadelphia, and a number of our research staff are from Philadelphia, so we know the scene pretty well. We're friends with a lot of the service providers there. We basically did snowball recruitment, talking to people. And we like getting down with the people because I need to hear their expertise. I need to hear their story, their experiences, their wisdom. And I'm very appreciative of the privilege to be able to get that wisdom. Just briefly, fairly diverse in terms of gender, fairly diverse in terms of age, so diverse in terms of race, ethnicity. But looking at the substances used, most are using this combination called Tranq. About a third are using stimulants along with that. 2/3 are injecting, and 1/3 are not injecting. About 2/3 have had wounds. Currently have a wound. So just to summarize, when it's a lot of work to interview 32 people and to analyze the data and to write a long paper about it, but just to summarize, here's what we found. The obvious, they're extraordinarily severe wounds. I've been studying skin and soft tissue infections for 25 years that I've been a clinically engaged harm reductionist. These are extraordinarily severe. They cause a lot of suffering. What emerged was this kind of a story which can be told fairly linearly, and that is that the Tranq dope injection, it burns. It burns when it goes in. The vein loss happens pretty quickly once this burning sensation is occurring. It doesn't have to be months. It could be a few weeks where the veins start to collapse. And then you get into this period of frustration, right, where you can't get the dose into the vein. I try. Maybe you think you get it in. Maybe you miss the shot. Maybe you intentionally skin pop. Maybe you go to the muscle. Maybe you go to the external jugular. So this frustration leads to alternative injections, both accidental and purposeful. And then once the injury starts to happen, the wounds start out as pimples. They move to ulcerations that rapidly occur following this vein loss. And people use the term Tranq burns, hence the name of the title of the presentation and the title of the paper that has actually just been accepted, publication IJDP. So one by one, let's talk about some of these themes. So Tranq dope injection caused burning sensation. The interviewer says, so how does Tranq feel when you miss your vein? Respondent, it burns, burns. Is there any other chemical that it reminds you of in terms of the level of burning, like if you missed a shot of Coke? Respondent, it burns a little less than the coke. Vein loss occurred following chronic drug use, chronic use of Tranq-Dope. Have people always had this much trouble injecting, or is this newer? Respondent, no, I don't think so. I don't think that the drugs have been so noxious to the veins either. Powder cocaine, yes. We all know powder kind of destroys your veins, but we really didn't know, or at least I wasn't aware, that Tranq would be just as bad, if not worse, than powder. Theme 3, vein loss resulted in increased injection attempts and the use of large central veins. I'm not sure the quality of how this is coming across, but you can see some stigmata from external jugular injections. This is not the person in the quote, but they were kind enough to let me take this photo. Different respondent, tell me about those large arm wounds. How did you get them? How long have they been there? Oh man, I've had them for about 3 years now. I got them, I used up all my veins from shooting the Xylazine. It tears your veins apart. You shoot one time, you lose your veins. So I've gone through every single vein you can dream of in your body, from feet to head to toe to neck, everything. Anyone sensitive to images? The next one's a little bit gruesome. Extensive. This is actually sort of a 5 or 6 out of 10. It's still superficial. The one on the left, it has necrotic elements to it, and very slow healing. The person on the right is in the phase of healing. They've been taking very good care of their wounds, and you can see various stages of healing. And here's an example of some of the incredible street-side nursing and clinical care that's going on to address this. So I promised you another method. We were so curious about this notion of burning that it brought up some of my prior research where I worked with Magdalena Harris, and we did samples of heroin from around the world to try to see if there was an underlying foundational hypothesis to why people were getting soft tissue infections. And we decided that heroin acidity, this is a hypothesis, heroin acidity, which comes in different forms based on the different sources of heroin in the world, leads to vein loss, leads to these perivenous injections, starts the nidus of skin and soft tissue infections in this case. But he said, maybe it applies to these wounds. So what's the acidity of Tranq-Dope? We didn't have approval to do direct, let me have your sample and send it to a lab kind of thing, but we asked Dr. Alex Grotulski at CFSRE, who has access to a large drug checking database. Philadelphia is doing a wonderful program there. It's at surveillance level. They have so many samples that you actually can monitor how the drug supply is changing. And we said, can you just test a few from the same time and location when we were there? And they did that. So this is exploratory. It's a tiny sample size. What did we find? So just to remind everyone, a pH scale, 0 to 14, where 7 is neutral. As we move to the smaller numbers, like 2, you're getting very acidic. For example, that's like lemon juice or red wine vinegar. So if we look at fentanyl and heroin, this is without xylazine, very acidic. Talking about lemon juice or red wine vinegar here. If we now add in samples that have fentanyl and xylazine, it's a little less acidic. So this is why we do science, right? To be a little bit surprised, like, whoa, okay, so it's not the xylazine. If we look at one sample, and again, this is N of 1, right? But that it matches what the typical sample at the time was in terms of purity of xylazine, purity of fentanyl, and the weight of the sample, we get, 3.9. So it's be sort of like injecting orange juice, moderately acidic. Looking at lab references for xylazine, we see mild to moderate acidity. And if we look at Coke, quite acidic. What we weren't able to do in this particular setting, we'll have to do this in further things, is to combine, right? A lot of people are doing speedballs with Coke. What's the acidity of that combination? So, to wrap up, the combined use of xylazine and fentanyl leads to vein loss, which increases the risk of subsequent skin and soft tissue injury. Hypothesis to hypothesis, we started with a hypothesis, and we're still ending with a hypothesis, but it's a synergistic one, a synergistic etiological hypothesis, that the acidity of the Tranq, particularly the fentanyl component, causes the vein damage, causes the burning that people are feeling, and the loss of vein access, and then these perivenous injections. And the xylazine, now injected perivenously, injected into soft tissues, because it's a strong vasoconstrictor, raises the likelihood of necrosis through poor oxygenation, to poor tissue perfusion. Possible harm reduction interventions include dilution, buffering and smoking. Back in the day, we did try some buffering experiments with this more acidic heroines to see if that was plausible, and the answer is yes. Was it widely adopted? No, but it was plausible. And I'm very curious about smoking, because, for example, the xylazine plus fentanyl we have in the West Coast, people are smoking it, we're not getting the wounds. Now, it could be that the xylazine component's much lower purity, so further research needs to happen, but maybe smoking. And stigma is a big deal here, right? These wounds cause embarrassment, shame, and we need culturally sensitive and appropriate clinical care, which I did see a lot of. They should be justifiably proud of themselves. Acknowledgements, the participants who were part of this research, my ethnographic study team. You see a photo of at least the three of the folks here. My NIH NIDA funder, and Dr. Alice Krutelsky, and you all for your kind attention today. Thank you.
Okay, thank you so much. That was extremely interesting and informative. I'm definitely curious to hear more about smoking as a means of harm reduction as a tool. So hoping to follow up on that later on in the questionnaire. This is a perfect segue into Kristin Schneider's work. Kristin is an epidemiologist and professor at Johns Hopkins University, where she also received her PhD. Her work focuses on improving access to essential health services for those who use drugs to reduce overdose incidence and disease transmission. Today, she'll be sharing her research on effective strategies for treating xylazine-related wounds and the development of a research-backed wound care protocol. Kristin, take it away.
Thank you very much. Can you hear me now? Okay. So thank you very much for that kind introduction. I'm also going to say, unlike Dan, I am not a medical doctor. I've just kind of face planted into caring about wounds. So please don't take anything I say as like official medical advice, because I'm in no way qualified to give you that. But I also want to point out some of my, okay, can't see their names yet, but they'll be there eventually. My amazing co-workers and co-authors on this presentation. We have two awesome nurses on our team who helped with the development, Susie, who's over there, and Jason, who is not here with us, but he's our certified wound care nurse who is providing services in accordance with this protocol in real time. So, okay, I'll have slides eventually. But just to say, the primary goal of the work that I'm presenting and the work that we've been doing is to fill this gap that really was identified when xylazine began to emerge on the East Coast, that there was a lack of practical guidance for how to treat xylazine wounds in harm reduction settings, and there was a really big need for the many different syringe services programs and other harm reduction orgs that we have. They're like, our clients desperately need help. They won't go to the hospital because of many, many terrible stigmatizing discriminatory experiences for obvious reasons. And so we wanted to create a wound care protocol that's really focused towards organizations that both have limited clinical capacity and are also working in harm reduction or street outreach, street medicine type settings. I'll have slides eventually. So in the process of developing this protocol, we did a few different things. One, we did a review of medical and harm reduction literature, both academic and gray literature, because there are a lot of existing resources about wound care, but many of them were not tailored or applied to xylazine. We also did a number of interviews with clinical providers who are currently working in mostly East Coast and also Puerto Rico-based harm reduction programs, providing wound care directly to people who use and inject drugs. And so we then took that information from those interviews and the review of the literature and synthesized it in accordance with some existing clinical protocols. Yeah. And there are existing nursing frameworks that we found that were very helpful, and then we, what I'm calling harm reductionified them, to make them a little less clinical and a little more considerate towards the practical realities of the lives that many of our clients face. Really thinking about structural vulnerabilities, being unhoused, lack of access to running water, things like that. Oh, yay, I have slides now. We are here. We went through that process, and that's how we thought about getting to where we are in this protocol development. And so one of the first questions people always ask is, do I have to be a nurse? Do I have to be a doctor to provide wound care? And the conclusions that we've come to, some medical providers will say exactly the opposite, so take it with a grain of salt. I'm not your medical director. I'm not anybody's medical director. Based on all of the information available, medical training is really not necessary for a lot of aspects of wound care. I mean, it's nice if you have a certified wound care nurse, which we do, we have the luxury of having the funds to be able to hire one, knowing a great harm reduction-oriented nurse, but it's not totally necessary. There are some aspects of wound care, and I will point them out, that really should be provided by medical providers, but for the most part, most of the things can happen and be done by anybody. But this really should depend on both the individual and the organizational willingness and comfort with doing so. Certain individuals might be squeamish, so you probably shouldn't make them provide wound care, right? Some individuals are much more comfortable in first aid versus what they think of more of as like a medical practice, right? And so thinking about your own individual comfort and willingness to provide wound care, and also thinking about your organizational's comfort and willingness. So if your organization operates under a medical director's personal license, they may have concerns about the liability of having lay persons provide wound care. And so that is something that will vary by every organization. But if you have someone who's on board, a medical director who's on board, I think any number of trained individuals from any walk of life should be able to provide really basic wound care. And so this is our first harm reductionified protocol framework. And it's really easy to remember because it's just the alphabet. These are the basic steps that when you're providing wound care to someone, you're going to go through in addressing their wound and how you're going to proceed. And I'm going to really focus in on the assessing and the deciding treatment pieces, but I'll just say a little bit about each of the steps before I move on. So when you're assessing the patient's wound and well-being, this is the step where you kind of want to get what would typically be thought of as history. But what's really important here, a lot of it is drug use history, right? Because one of the, and also like socio-structural vulnerability and things like that, understanding that person's unique circumstances is going to inform everything else that comes after. Because you don't want to give the advice of you need to wash your wound in clean running water every day and change the bandages to someone whose only access to water might be from a stream because they're living in a tent in the woods, right? That would not be good advice. So you're going to assess the wound, and I'll go through a few different things about how assessment should and could work. But then you would hopefully, ideally, bring in a multidisciplinary team to promote health holistically. And this doesn't just mean, in a traditional medical sense, this would be bring in a podiatrist, bring in a wound care specialist, bring in an addiction medicine person. That's not what we mean when we're saying this. What we mean when we're saying this is we want to collaborate with trusted service providers. Social service providers who can get access to food, because if someone does not have sufficient nutrition or sufficient protein in particular, they're going to have a really hard time healing their wounds. Access to housing resources, access to insurance, Medicaid, those kinds of signups. And if you have trusted medical providers that you can bring in at this point, that's great, but many organizations have a really hard time finding these collaborators. We certainly have. And I live and work in Baltimore, which has more hospitals than it has people, it feels like sometimes. And then once you have your team and your folks who are involved, you want to kind of address the underlying causes of the wound. And so the cause of a xylazine wound is use of xylazine in many cases, right? But what we mean address the causes is not necessarily that person needs to stop using drugs. But one thing that we found in talking to clients and our folks is that many people inject into their wounds, which is really something that can slow healing a lot. So having harm reduction conversations, if you want this wound to heal, maybe use your drugs another way. Maybe there's other ways that can help achieve both your desire to use drugs and also your desire to heal the wound and be healthier in that respect as well. Also connecting people to drug checking. One of the things that came up early, because we started this work really when Xylazine first started to be identified in the eastern coast of the United States. Lots of folks were using Xylazine, getting Xylazine wounds, but had no idea what Xylazine was. They had no idea why. And so linking folks to drug checking services, so if they want to avoid Xylazine, they have some capacity to do that. I know many markets are very permeated at this point with Xylazine, so that can be challenging. But if those resources and options are available, those are different ways that you can address some of the causes. And then I'll talk later about the deciding the appropriate treatment and also how you can empower clients to care for themselves. So step one is this a Xylazine wound? And Dan just showed quite a few pictures, and I didn't include any photos because I suspected he might include photos. So you only had to look at them once, but identifying Xylazine wounds, they can present a few different ways, and they often start small and get larger quickly. And so early identification and intervention is also another way we can begin to address Xylazine wounds from a harm reduction perspective. And in particular, for folks of color, identifying Xylazine wounds can often be a lot more challenging because they start as dark patches under the skin. And so if someone has dark skin, that's harder to identify, or they're more often to be overlooked by clinical providers than someone who has very pale skin, right? And so that's something to keep in mind as well, that there are racialized elements to the wound care folks will receive in clinical settings, and to be aware in your practice and your client population, to be aware of that maybe implicit bias that might be present. And so when you're identifying a Xylazine wound, you gotta know if the person used Xylazine, whether they know it or not, right? So asking questions about experiences that might have been unexpected that seem like Xylazine, being heavily sedated when they weren't expecting to, things like that. And wounds appearing away from injection sites is often another typical indicator too, usually on extremities, so arms or legs. Xylazine wounds don't seem to typically appear on torsos, so that is often another good indicator that it might be a Xylazine wound. And as Dan had mentioned, they often start as a pimple or a blister, and then can become larger red or purple discoloration. And when Xylazine wounds are really advanced, because often many folks present for wound care when they've had the wound for a while, they can appear as black, dead, necrotic tissue, or hard eschers, so really like thick, hard, dead skin on the top of the wound. So those are some typical indicators, but they can present a number of different ways. And there are this was one really important point to make. As harm reductionists, we often want to be able to provide as much as possible in-house for our clients. But one thing that is a really high risk when you're dealing with wounds is sepsis, and sepsis is emergently life-threatening. It can result in loss of life and limb very quickly in a matter of days, or if it's an advanced enough infection, in a matter of hours. And so folks who have signs of systemic infection, so like sepsis, osteomyelitis, there are other ones, really need to be referred to hospital-based clinical care because they will often need intravenous antibiotics and regular and continuous monitoring of vitals to ensure that they're able to survive. And that's really hard to do oftentimes. I know many of our clients have had terrible experiences at hospitals. I'm sure that's relatable many places. But one of the best things we can do proactively to address the issue of sepsis is to try and build relationships with a trusted medical provider that, if I have a person who is in this emergent state, can you get them in? Can you treat them well? Can you get them well managed on bupe or methadone so that they're not in terrible withdrawal? Because that's often a reason a lot of folks leave hospitals before their treatment is complete, is that they're just suffering because they won't induce them on bupe or get them to a comfortable state, manage their pain. So sepsis is one of the really big risks, and that's an indication when the person is really not someone that you can necessarily treat in this outreach street medicine setting. Some other indications are if there's exposed bone or tendons or things like that, trying to provide that treatment as a lay person has a real risk of doing more harm than good when wounds are that advanced. And also when wounds are located on highly complicated underlying structures. So what examples providers we talked to gave are wounds near eyes. That is maybe not something that, if you're not a trained medical professional, you probably don't want to mess with, just because, again, there is a real risk of harm. And just as a note, impaired motor function or weakness, because these wounds often appear on extremities, rapidly onset weakness or impaired motor function can be indicative of nerve damage related to the wound or potentially infective arthritis, which can also progress to sepsis and be life-threatening. So those are some significant indicators that when you might want to refer someone to a hospital or an outpatient medical center that you know and trust and can hope they can get the quality care that they need. So then we go to our next framework that we're using. It's called time. And this is when you're looking at the wound itself, how do you assess the features of it and decide, what do I need to do to help this person start healing? So first question is about tissue. Does the tissue appear viable? So often xylazine wounds have that black necrotic tissue, which, by the way, is not necessarily indicative of infection. People always think it's black, it must be infected. Not necessarily. It can be. These wounds can be infected, but they're not always infective, even if they look pretty severe. So you want to look at the tissue. If it's hard and thick, you're like, okay, we're going to need to do a debridement, which is just a fancy word for getting rid of the dead stuff. And so you're going to look at that. And then think about, does it appear infected or inflamed? So is it oozing? Is it red and swollen? If the wound appears to be infected, a localized infection, and this is really a place where you use an abundance of caution, it's possible that the wound can have a topical infection, I guess is the way to say it, versus a systemic infection. A topical infection you could be treated with, triple antibiotic cream, bacitracin, lots of different things. Silver hydrogel is one people like, but it's very expensive, so maybe get something else. And so if it's infected or inflamed, there's different things you can do, right? You want to cleanse the wound. You might provide topical antibiotics if that's appropriate. If they have any of the signs of sepsis, though, again, proceed with an abundance of caution because that can become life-threatening very quickly. NSAIDs like Advil, also if it's inflamed, also could be a great choice for folks to address some of that inflammation. Then, for M, you're going to look at the moisture balance. And in wound care, the general principle is you want to make wet things dry and dry things wet. So if the wound is oozing or has a lot of moisture, or the skin is masticated, which basically means it's like wrinkly and kind of soft and could be to the point that it's deteriorating, you want to dry that wound out. Xylazine wounds often tend to be on the other side where they're very dry. And so in order to get that wound to start healing, you need to moisten the wound bed and get it to a place where healthy cell growth can happen. So we're going to mostly talk about how to make dry wounds wet later in this presentation. And then you're going to look at the edges as well. So, and that meaning literally the edge of the wound, right, the outside circle. A healing wound will have what's called advancing edges, or the wound will be getting smaller and the edges will look pink. And that is a sign of healing. If there aren't advancing edges, or if the edges are raised, or what's sometimes called rolled, which kind of like the wound's belt is on a little too tight and the edges are hanging over, those are signs that the wound is not healing well, and that additional steps will be needed. And so by doing this assessment and looking at these different factors, you can decide on your cleansing, your debridement, and then your wrapping procedures. So like I said, debridement is just a fancy word for removing dead tissue so then the wound can heal better. In most cases, your cleansing and your debridement are going to kind of happen at the same time in a street outreach setting. Cleansing with soap and water or saline and soap is usually sufficient. You don't want to be using peroxide or rubbing alcohol on these wounds. That prevents healthy cell growth. It disrupts the development of new cells. There are fancy wound washes available, like Vashi and stuff like that. They're really, really expensive, much more expensive than soap and water. And so I'm going to say that a lot because there are a lot of really expensive wound care products, but a lot of us don't have a ton of extra money to buy wound care supplies. So soap and water is usually sufficient. And in the process of cleaning the wound with soap and water, you can do what's called gentle mechanical debridement, because that is usually warranted in the case of xylazine wounds, which basically means you're going to use a washcloth or some gauze or maybe a Q-tip, cotton swab type thing, and you're going to kind of rub it in gentle circles and remove a little bit of that dead tissue at a time. It's an important note that you don't have to do all of the debridement at once. Often when folks go to the hospital, they will do a massive debridement procedure, remove all of the dead tissue at once, but in outreach and harm reduction settings, one, that can be incredibly painful. Two, It's like if you're going to see this person on a regular basis, you can treat the wound over time because these wounds take time to heal. You don't have to do it all in one setting, whereas ED professionals often are like, this is the only time I'm going to get to see this patient. I have to do it all right now. And that often leads to a worse experience. So gentle mechanical debridement, or washing it real good with a washcloth, is usually your first step. You can also do what's called autolytic debridement using Meta-Honey. I don't know if folks are familiar with Meta-Honey. People seem to really like it. It's basically irradiated Manuka honey that's sold at a medical grade, and that can break down some of the dry dead tissue. Again, Meta-Honey is really expensive, or comparatively very expensive to some of the options that you can have. Importantly, Meta-Honey is not just regular honey you get at the grocery store. Some people think that and they're like, oh, we ran out of Meta-Honey, let's use regular honey. Please don't. Regular honey does have some antimicrobial processes, but it's not irradiated to remove the other bacteria and things like that that might be harmful. Also, I want to mention in relation to Meta-Honey, if you're dealing with a primarily unhoused population, Meta-Honey might be a bad choice for you. We had a situation in Maryland where one of our orgs, the orgs that we work with or collaborate with, was giving out Meta-Honey to their wound care clients. But most of these clients lived in an encampment in the woods, and then the Meta-Honey, the packages were left unopened, attracted lots of insects, and the encampment became infested. And it became a huge problem to get these folks to a new uninfested area. And so that's just something to consider. Lots of people really like Meta-Honey, and lots of clients really like Meta-Honey. So if you have the budget and your folks are, relatively stably housed, it could be a good choice. But it's certainly not necessary, and it doesn't mean you can't do wound care if you don't have the fancy wound care supplies. So, and then after you've cleaned and debrided your wound, you're going to dress it. And so there are generally 3 layers to dressing your wound. You're going to have the contact layer that touches the wound. And so typically for xylazine wounds, since we're trying to make the dry wound wet, we're going to use some sort of petroleum-based or impregnated, is what they call it. I think it's a weird word for gauze. But you're going to want to use some sort of wet or moisturizing contact layer. Xeroform is a very popular supply. Again, on the expensive side, but you can get to basically the same thing as a Xeroform if you have gauze, petroleum jelly, and some kind of antimicrobial ointment. And so there are lots of ways in wound care that you can save money with a little bit of extra effort. Yeah, okay. I only have 2 slides left, I promise. So you have your contact layer that's going to, in most cases, moisturize your wound. You're going to have an absorbent layer, which can be, again, a number of different things, ABD pads, sponges, gauze, that are going to absorb any drainage, things like that. And then you'll have your outer layer to make sure the dressing stays in place. And this is another place to consider the structural vulnerability of your patient or your clients. If someone is not in a place where they can clean and change their bandages every day, use things that can last a week. There are wound care supplies that can last a week. There are outer layers that can stay in place for 3 to 5 days. That will be more indicated for folks who don't have regular access to running water to be able to clean the wounds and keep their wound care supplies in a good place. And on that note, empowering your clients is essential. Most clients are more than capable and really eager to participate actively in their wound care. And so if you give them the education and the supplies that they need to do that, they will. And for the most part, they do a really good job. And it also makes them more likely to trust you, to come back, to continue to care for that wound, and give you a better chance of getting that wound healed up. And so I had to go through that fast, but you can scan my QR code, and then I'll email you some stuff that has more information. It's going to ask you for your name, email, org, I think, and I don't know if you want to know anything in particular. So if you do my QR code, I promise I'll email you some final documents.
Honestly, too tall for me, guys. Okay, never mind. Okay, that was amazing. Thank you so much, Kristin. That was super informative and really helpful to see how we can use community to guide us in these wound care protocols. I now want to introduce Chris, but before I do that, I have a small announcement to make. It is Chris's birthday today. So we got you something, Chris. The question mark, 'cause I don't know your age, and so I figured.
35.
Perfect. Well, the question mark it was. Okay.
Oh, it is a trick candle.
Oh, it is? Oh. All right. Okay, good. Okay, so Chris, the wonderful Chris Rintoul, is the head of harm reduction at Cranstoun, a harm reduction and social justice charity in the UK. He has worked in drug treatment and homeless services since the early 1990s, both pre and post ceasefire era in Belfast, Northern Ireland. Here, he developed pivotal accommodation services for those who inject drugs while writing, curating, and developing practice guides, articles, and trainings for care workers and clients alike. Today, he'll be talking about Nitazenes, a strong synthetic opioid that has recently emerged in the UK drug supply, and essentially how to keep folks alive. Nitazenes, right?
Nitazenes?
Nitazenes.
Okay.
Sorry, guys.
Thanks very much. Thank you. And whoever did that, I am going to, I'll get you back. All right, thanks very much. Okay, and thank you very much to everybody who's still here at the end of a very long day. I remember by this time in the last session yesterday, my eyes were drooping, so I'll not take it as an offense if anybody falls asleep in the middle of this. So I am not a doctor, unlike these other learned folk here. The only claim to fame I can actually ever say is I was once described by Pat O'Hare as like a young Ethan Nadelman, right? But you're about to find out that I am nothing like Ethan Nadelman's skills at oratory, okay? So anyway, that's that. So in 2023, in the UK, actually in the West Midlands within England, there was a sudden rise in both fatal and non-fatal overdoses, and some of my colleagues here were involved in responding to that, along with myself and other colleagues, not just from the organisation I work for called Cranston, but from other places as well. Okay, so I have the the real privilege to be here and present on behalf, of this lovely group of people here. Those of you who aren't from the UK, don't worry if you don't recognise the faces or the names, etc. Although you would probably know two of the faces in the photograph there on the left. I think the pointer is there. No, it's not. Got it wrong. Okay, you might recognise the O'Hares there, Pat's daughters. And really, it was a bit of a bombshell in 2023 in the summer, and there was a lot of like, what the hell are we going to do here? Because this is unusual. It's really worrying. Nobody really knows what's going on at that point anyway, but we knew we had to do something. But the context wasn't great. I'm from Belfast in Northern Ireland, and I had always worked there up until 2021 when I joined Cranston. I was completely naive to what English drug treatment services were about, how they were delivered, the relationships between them, etc. But I soon found out that there wasn't always a very collaborative approach. It was a very highly competitive market between those different services. And I suppose if I have one thing that I've been able to do consistently, reasonably well throughout my career is collaborate with others in other services and other disciplines and other organisations and things like that. It comes, thankfully, fairly naturally to me, and I'm not really a fan of the kind of competitive stuff that goes on a day-to-day basis. Anyway, we all thought, right, look, we need to do something here. Let's meet, let's learn a bit more. There were conversations actually that precursed that. One of the people involved in those conversations was Dr. Judith Yates there, halfway to the back there. And she'll remember this kind of era pretty well. I had a role as the harm reduction lead for my organisation, and there were others in those other organisations, or NGOs as they're known here, who had similar roles. And we felt that there was really no point in each of us guiding our own organisations saying pretty much the same thing or maybe slightly different things. What would be far better and far more effective overall would be to get consistent message that would go out through all of those organisations, which would span up and down the UK, really, certainly across England. So we started to say things like drugs are changing, watch out, overdoses are occurring, etc. And we knew that those messages would be more credible if they came from across the sector rather than just by each individual organisation. And there was a greater likelihood of people seeing the messages if they were joint ones. In case if you haven't come across Nitazenes before, they are a novel group of potent synthetic opioids, not dissimilar as opposed to fentanyl and its analogues, but many times often much stronger, and certainly a lot stronger than heroin. So we began to see these cropping up. Deaths seemed to be occurring. We were always a little bit behind the curve because you just don't know what's causing these things until there's proper testing done, etc. But we knew there were in some pockets of heroin across the UK. There were also in benzodiazepines, the novel benzos, I suppose, like Etiology, etc. And more recently, we've seen them within fake oxycodone or OxyContin supplies as well in the UK. So we sort of felt, right, what can be done? Well, safe supply, of course, that would be fantastic. But we're nowhere near that really in the UK. It would be fantastic if we got there, but that is not an achievable goal in the short term, and we needed to do something fairly quickly. So another few things that we thought about was, okay, drug checking and testing was a no-brainer, and that became slightly better and slightly quicker across that time. There's been no really perfect solution to that or perfect examples that are easily and readily available quickly upstream at the point of somebody's use of drugs, or even better still, just before it. But it is definitely improving. Attracting people into treatment was a key goal for us. Treatment needs to be attractive. If I have one thing that has kind of been quite a shock to me, or really shocked me when I first joined, is English drug treatment, was the sense of the people that really most need to be in treatment are not in it. And there's reasons for that, which I'm not going to go into in any depth now. We can do that some other time. But we needed to make treatment attractive. We needed to make it quick, and we needed to make it people easy to get into, get therapeutic, dosing from any substitution drug, and make it easy to get back into as well. Naloxone, of course, we stepped that up, as did all organisations. And a lot of more overdose awareness as well. So nothing in that is probably a great surprise to you. It's all fairly sensible. But based on some work that was done by the wonderful Lynn Leo Jeffries, I'm not sure if they're here in the room at the minute, from Euro Input, who'd done some great work in 2023 about very simple messages that we might be able to get people to hear, to see, and to understand. And so we kind of reframed some of that and made it much more relevant to an English context, whereas Lynn Leo's work was relevant to a more broader European context. And whilst those were good, and I think they're good messages, the problem with all kind of public health messaging aimed at people who use drugs is typically it's a list of do's and don'ts. And okay, that's better than saying nothing, just ignoring the problem. But what we felt would be far more effective is we said, look, we actually don't know what the context of overdose is for any particular individual. We don't know where they'll be. We don't know where they will, who they'll be with. We won't know what potentially they might be using. They may not know potentially what they'll be using. So there's all these unknowns. So what we wanted to do was go, right, okay, but the person that uses drugs which could be contaminated has got a far better idea about these unknowns than we will. So what we want to do is make them the centre of a safety plan, which we called a Stay Alive plan. And so became not do's and don'ts. It became, imagine how an overdose might happen to you, what would be around, who would be around, and what might you be able to do to prevent that overdose becoming a fatal one. So things like, I'll text my mate 5 minutes before, I have my hit, and I'll say, look, there's a key out the back of the door under the mat. If I don't reply to you when you ring me in 5 minutes, let yourself in, there's an naloxone beside me, etc. So very simple things that could actually have a really powerful effect on somebody and prevent the loss of their life. But the key thing was about you have to imagine for yourself what an overdose might look like, how an overdose might occur and how you might make sure that it doesn't become a fatal one. So that was the central idea. There's a QR code there if you want to download the materials, which were very kindly put together for us by Lucy and Maddie from HIT and also of HRI, as you well know. So those are available, and they're just simple wee things. And we wanted people who work in drug treatment services, like key workers and others, to just have these simple conversations with people, let them write down a plan for themselves and take it away. It's not for us. It doesn't sit there in their notes and records. It needs to go with that person. Fair enough, if treatment services need to keep a copy for it, that's fine. But the key thing is that it goes with that person when they leave that day. We thought that we would like to do something in 2024 together, and we built a fairly strong, relationships between ourselves. So we came up for International Overdose Day last year, which is the end of August, with this idea about having a poster campaign that would be in train stations and this and that and the other place. It wouldn't just be in kind of treatment services walls. This needed to be out in the general population. We would have loved to be able to put something on here, and the astute members in here will see that there's no mention of naloxone. So although we're saying, opioid OD, do something, which is an encouragement to the reader of the poster, we couldn't mention naloxone because it's a prescription-only medication, and that's ridiculous. I mean, in the context of the overdoses which are occurring, and sadly probably yet to come and probably get worse, we should be able to mention naloxone, but the current legal position is that we couldn't, which was a real shame. Okay, another thought that we had, and this is just a group of people coming together and trying to think about things together, is that we thought that our own organisations would only really be showing a true commitment to reducing the chance of overdose deaths if they were implanting in each person's mind within those organisations who work with people who use drugs. Firstly, how can I ensure that the person the person I'm working with here in front of me comes back to see me? That thought goes on in their mind. And that, of course, will lead you to the thought of therapeutic alliance and hopefulness and all those sorts of things. So what is it about me that makes sure, or makes it more likely that that person will come back and avail of more help? And with that, and just as important is, how do I ensure this person is alive in order to be able to do that? And we think that when those are the thoughts that are front and centre of our drugs workers across England, that's when we've actually taken the Nitazenes threat as seriously as we should do. I want to finish just with another photograph and a very short video. Am I okay for 2 minutes? Great, okay. These are the lovely folks that I've been working with. When this video starts, you'll notice that there's quite a diverse range of accents there. There's a couple, there's a Cockney, there's two Scousers, that means Liverpudlians. There's me from Belfast, and I do speak English, by the way. It's not Gaelic you're hearing right now. And another guy who's from somewhere near Manchester, I believe, right? This is not entirely relevant to this presentation, but I felt bad that these guys weren't able to be here as well. So I just want to introduce you to them and some of their thinking in a very short video. If I know how to get it to work. No sound. you mind restarting that? Can you restart? Yeah. Thanks.
I think our offer needs to capture people where they are, and that I love outreach. I think, like you were saying, boots on the ground. You can always tell a good outreach team by the footwear and their headwear, whether they've got a decent coat. But actually, there's a whole piece of outreach about reaching people in that virtual reality place online that I think everybody is really fearful of. But we've got lots and lots of people who interact entirely online with their drugs and the way that they take those drugs and then interact with other people with those drugs. And where is that harm reduction offer? Where is that information? Where are people getting that information from? And where are they getting any kind of support from? I think is a really big place that we just don't look at that. We look at building something and expecting people to come from.
It goes back to, again, some people's perception of harm reduction is needles and syringes or naloxone or overdose prevention. Of course it's that, and of course we need to do more than that. But it's much wider than that. It's an ethos, isn't it? It's a way of being, it's a way of a culture of a service. And some treatment services will have that. Methadone treatment or buprenorphine treatment is harm reduction in itself. But again, it goes back to that, but if that's not for you, you're not really going to engage in that environment. So harm reduction needs to be fluid, it needs to be flexible, it needs to be mobile, it needs to be responsive.
Not sure that's the end, actually, but. You want me to press play? Oh, no, it's all right. That's only starting from the start again.
I think our offer needs to capture people where they are. And that
Well, not torture you any longer. All right. With that, I'll shut up and they'll shut up as well. All right. Okay. Thanks for the birthday.
Thank you, Chris, and thank you for spending your birthday with us. But truly, at a global conference like this, it is really beneficial to hear about how orgs like Kristin are doing work to navigate drugs and overdoses that we may never have seen in other places, So it's very helpful. We are almost done. We have one final person, Dr. Greg Rosen. Greg is also a Hopkins PhD alum, actually, now at Brown University as a professor and research scientist. His research seeks to optimize HIV and harm reduction service delivery for those who use drugs. He's done research in both sub-Saharan Africa and in the US. His recent work includes evaluating community-based HIV treatment models in Uganda and researching reverse motion detectors for overdose prevention in Boston. Shout out to Boston. Today, he'll present his research and pilot testing the efficacy and feasibility of restroom motion sensor systems in Rhode Island.
Oh, yeah.
The floor is yours, but the slides are wrong.
Yes,
Yeah, it's
so
the other one.
thank you very much. I'll just start talking, Mrin, if that's okay.
That's okay, yeah.
Thanks very much for that very generous introduction. I know that we're getting the slides programmed, and I really appreciate everyone sticking around to be with us. Gracias por la invitación. Voy a hacer la presentación, lo voy a hacer en inglés, pero si nuestros compañeros tienen una pregunta después o quieren hablar después, yo hablo español, así que pueden compartir en la conversación después. So for those that didn't catch that, I was just telling our Spanish-speaking colleagues who graciously invited us to be here that I'm going to be presenting in English, but I've offered folks to engage in Spanish at the end if they would like. I also have the honor of presenting on behalf of a really amazing team at Brown University, Pony, Community Care Alliance, as well as other collaborators, both in the state of Rhode Island in the United States, as well as elsewhere on this multi-phase project that we've been engaged in that focuses on motion sensor systems. So maybe just to quickly have a little bit of a dialogue here. Could you just raise your hands in the room if you have heard of motion sensor systems or restroom? Oh, that is a lot more folks than I thought. Okay, awesome. So the results that I will present here, do not represent you all in the room necessarily. But just maybe to give one of the messages away before I even start, we see that people really are interested in these technologies and want to implement them, but know virtually nothing about them. And so what we are hoping to do as part of this work is essentially to pilot these technologies in different settings to try to understand how they are implemented, what folks think of them when they get implemented, and how we can sort of co-design or develop strategies that make them more palatable and feasible within the context that they're implemented. So maybe for some background to start off, we know that unmonitored drug use, also called solitary drug use, using alone, lots of terminology to describe this, is a very common phenomenon, but strategies to increase safety during these types of events are underutilized. And solitary drug use can really challenge or limit the effectiveness of many of the strategies in our harm reduction toolbox, like naloxone, which require bystanders oftentimes to be present during an overdose event in order for them to be effective. So maybe just to draw home that point, in the United States, where I come from, approximately 92% of overdose deaths are in individuals who are found alone at the time who overdose. So we know that this is a major issue that warrants our collective attention. And furthermore, fewer than half of these overdose deaths occur in the context where there is a bystander that is present. And so we have to think very creatively about how we bridge the gap between our existing harm reduction interventions and solitary drug use. Oh, that is the backwards one. So there's obviously many reasons that people are using drugs alone, and that is both born out of necessity as well as preference. So by that I mean that some people might prefer to use alone. They want the privacy, they might not want to be bothered by anyone else, and makes the experience more enjoyable for them. But it sometimes is also a necessity because they may have very intense withdrawal symptoms at that moment and need to alleviate. They may not want others to know they're using. So there's many different reasons folks are using alone at different times in the day or even in their use journeys. And so motion sensor systems have emerged as these recent technologies that can help us expedite detection and response to overdoses that might happen in bathrooms, which, as many of us probably can imagine, are places where there's a little bit more privacy for folks to use alone, right? So there's two common motion sensor technologies in the US and Canada that we are studying, or at least that we are aware of. The first is the product that I've shown here, which was designed by Brave Technology Co-op out of Vancouver. Basically, the way that this system works is that it detects the absence of specific micro movements in a single stall bathroom, and it sends an alert to a designated responder phone. So an individual is privately alerted on a cell phone when an alarm, a quote unquote alarm, is triggered in the bathroom, which indicates a potential emergency. I'm again going backwards, excuse me. So there's also this other product called Lifesaver Alert, which was designed in our backyard in New England, which is a very similar system to the Brave sensor. However, this actually, as the name implies, is a very loud alert. So it essentially has ambient alarms on the outside of a bathroom that go off, or like they're released when triggered, whatever the word is. Go off makes it sound, very Gen Z, but these alarms are triggered, and they're very loud alarms to let folks know there's a potential emergency in this bathroom happening here. One of the advantages of this technology is that it can be programmed in such a way that it can be designed for multi-stall restrooms. So basically, in brief, the way that these technologies work in practice, the alarm is triggered, it alerts a responder to essentially show up at the bathroom where the alert is coming from. Depending on what the outcome is in the bathroom, folks may, if they suspect an opioid-involved overdose, they may administer naloxone. They have the luxury of having oxygen. They may provide oxygen support, rescue breathing, or they may assess that it's another type of emergency or no emergency at all, and if required, summon emergency medical services. So what we sought to do as part of this work was to identify really what is going to make these technologies work for different organizations in practice in the state of Rhode Island, and really to evaluate their early implementation. And so I'm going to really be talking about the formative phases of this work, which we sought to characterize acceptability and feasibility of these technologies in different sort of community organizations. And I'll talk a bit about what those were in the forthcoming slides, but these are places with high traffic bathrooms. And then secondly, we conducted focus group discussions where we sought to explore different barriers and facilitators and ethical dimensions of implementing these technologies with a focus on both staff of specific organizations that could implement these as well as bathroom users. So in other words, a lot of, it would essentially be folks who are using drugs that could benefit from having this kind of technology in a bathroom. Our third aim, which is ongoing, I will not present today, but can certainly comment to it as time allows, is related to actually understanding the safety and effectiveness of these sensors when they're installed in bathrooms. So I'll talk briefly about the survey that we conducted with 100 organizations. The map that you see pictured here is the smallest state in the United States geographically. That is Rhode Island, where we come from. Don't let the size of the map deceive you. It is the smallest state. So it's probably, for those that are in the back of the room, I recognize it might be a little difficult to see. What we started off doing was we used publicly available data from the emergency medical services callouts to identify opioid-involved overdose hotspots in the state of Rhode Island, which are pictured here on the map. Within each of those hotspots, we then identified businesses that were in those catchment areas, to sort of businesses, community organizations, really like a heterogeneity or diversity of workplaces where there are bathrooms or at least some kind of public-facing restroom. And we wanted to really ask them about their current overdose response experiences, practices, and what their perceived feasibility and acceptability of these technologies were. And so by feasibility, essentially what I'm referring to here in more simplistic terms is their confidence to actually use these technologies in their workplace. And then in terms of acceptability, it would be how comfortable they are with having these technologies in their workplaces. Yet again, I keep messing this up. Sorry, folks. So I think unlike the straw poll I took at the start of the session, there was very low awareness of these technologies amongst all the organizations we surveyed in Rhode Island. So approximately 4% of individuals that completed the survey were aware of these technologies, but as you can see here, folks were excited about the prospect of these and felt comfortable that these could be implemented well in their workplaces. And so the bar chart that I'm showing you here, in yellow you see acceptability and in blue you see feasibility. We've stratified the acceptability and feasibility data by different types of establishments. So you see that really a lot of the social services organizations, so for example, community-based harm reduction centers, drop-in centers, those kinds of spaces really had very high levels of acceptability and feasibility. And in other settings like housing facilities, it was certainly lower, definitely not suboptimal, but certainly lower, which I think speaks to some of the concerns around maybe disruptions to workflows in very crowded housing shelters or disrupting clients at all hours of the night with alarms. So the other thing is that despite all of this pre-existing acceptability and feasibility, a lot of the organizations we surveyed really had limited existing infrastructure for overdose response. So you can see here that fewer than half of them had existing protocols for overdose detection. Fewer than half of staff were actually trained in using naloxone. Fewer than half actually had naloxone on site. And then about a third of organizations had a recent history or any history of an on-site overdose. So essentially, despite the enthusiasm for this, I think there's a lot of room in terms of capacity building to support organizations in being overdose response ready in the context of these technologies. So as I mentioned, we also conducted focus groups with both clients of different organizations as well as staff. They were in separate focus groups because we wanted clients to sort of speak freely. In some cases, you can imagine it in housing facilities, there were strong prohibitions against drug use, so there could be really severe implications of being found with drugs or even potentially overdosing, like being evicted if one were to be discovered with drugs or drug paraphernalia or even in an overdose circumstance. So for that reason, we separated the focus groups. And many of these the focus groups really focused on providing a brief demonstration of the technologies. So giving folks a 5-minute orientation to what these technologies are, what they do, what they don't do, and and then opening it up for a semi-structured dialogue around what folks thought about it. And so one of, I think, the most potent things that I think describes the essence of what we learned from these focus groups is that a lot of both clients of these sites as well as staff really described sort of a Swiss cheese model of overdose response. And by that I mean is that folks did not see this as a silver bullet. Folks really described these as an additional tool, and to use a direct quote from one of our participants, an extra set of eyes. So when one overdose response or detection service, for example, using with a bystander, manual bathroom checks, when one of those don't work, this is the backstop. So I think that really, in a lot of ways, summarizes what we learned from our focus groups, is the enthusiasm for these technologies was really underpinned because it would complement other things that existed. It wouldn't replace them. So as you can see, there were a number of facilitating factors that really drove people to want these technologies available. So giving folks peace of mind. As you can imagine, manual bathroom checks cause a lot of stress for both staff and clients. And so being able to have a technology that sort of took manual labor out of that process, provided both staff and clients additional security in that level. Again, privacy protection. So especially with the Brave sensor, the alerts were not these loud alarms that would draw everyone's attention to a bathroom. It was instead designed the technology was designed by people with lived and living experience such that it sends a private alert to someone who can sort of discreetly do a bathroom check and then sort of triage as needed. One of the other things is folks anticipated these kind of technologies would really bridge trust between staff and clients. As folks can imagine, with manual bathroom checking, there's an element of invasiveness that can come with that. So imagine if you're not responding because either someone might be nodding off or just distracted in the bathroom, but not necessarily having an emergency of any kind, it can feel really invasive to have somebody knock very loudly or violently on the door or potentially even barge in. And so the technologies were perceived as a way to sort of eliminate that ritual in a lot of these settings. And so folks really thought that these could bridge trust between clients and staff. Furthermore, if someone could be revived successfully earlier in an actual overdose event, there was some perception that there would be fewer ambulance and police callouts because folks would feel more empowered to respond earlier, which would result in less likely, potentially life-threatening consequences of an overdose. And then the technologies were also described as, based on the price points given at the time, as relatively affordable for a lot of these organizations. Nevertheless, I think it's important to also acknowledge some concerns that both clients and staff shared. So for a lot of sites, I'm thinking specifically housing facilities, there were tremendous consequences of being discovered or being revived from an overdose or potentially being found with drugs. This could be the loss of employment if you're a staff member at one of these sites, or if you are someone who lives in one of these spaces. This was also a perceived tremendous consequence, and this is why folks did not want any sort of passive monitoring of their drug use, which is exactly what these technologies are doing. There's also the consequence that if there is an emergency, that emergency medical services would still be summoned, resulting in police also responding, resulting then in continued over-policing of folks who are using drugs and the people supporting them. Even though these technologies are passively monitoring in the ambient environment micro movements, so there's no audio or video being recorded, the second folks see these technologies and interact with them, they wonder how these technologies are designed in such a way to see what is happening without capturing audio or video. So I think there's this inherent, sometimes I would call it a mistrust of these novel technologies because folks don't automatically trust that the folks delivering them or making them necessarily have the best of intentions. And so I think what this really emphasizes is that there has to be trust not only between staff and the deliverers of these technologies, but also the technology itself and its manufacturers. And then lastly, staff sort of described concerns around false alarms and just the burdens of having to respond to a lot of false alarms and what that would do to just client workflows to staff workflows in the workplace? Would this distract from their other responsibilities? Would there be compassion or alarm fatigue as a result of having to respond constantly to alarms that may not actually be for emergencies? So I think a lot of the anticipated barriers to implementation were strong, and folks were not afraid to share them. But nevertheless, that did not necessarily diminish people's enthusiasm about the potential of these technologies. So it really suggests that we need to co-create and co-develop strategies collectively that are responsive to the needs and preferences of both clients and staff, as well as consider the context in which these technologies are implemented. And so I think this is really where research practice partnerships are very powerful. As evaluators that are seeking to understand the effectiveness of these tools, we really owe it, and I think we really require strong allyship and collaboration with harm reduction organizations, community-based organizations, and other sort of thought leaders in this space that are on the front lines that really can sort of have open lines of communication that otherwise might not exist if we're working exclusively with a manufacturer. And I think it's also important to re-articulate the ethical dimensions of this work. Again, these are technologies that are designed to, in some ways, to take the human labor out of this work, which has its benefits, but also has very strong ethical implications for everyone involved. And I think constantly recentering attention to those ethical dimensions is critical. Had to mess up one more time before I finished. And I think we also just to, I'm a researcher, so I feel like I need to just advocate for always more research. But I think what we need is more research that shows how these technologies operate outside of a laboratory and how they actually operate in the real world. I think ethnography specifically is a very powerful tool to understand how these technologies, when they're taken into practice in real world uncontrolled settings, how they sometimes gain a life of their own, right? And I think with that, I will just acknowledge the many, many folks from Rhode Island Hospital, Brown University, Rido, Brave Technology Co-op, Pony, as well as RIEOHHS. Of course, all of our amazing participants across aims of the study, our various community partners, as well as our COBRE Community Advisory Board. Of course, we acknowledge funding from the NIH and the COBRE on opioids and overdose at Rhode Island Hospital. This work is really led by Dr. Ju Park at Brown University, a longtime collaborator and friend of mine. So I have the tremendous privilege of presenting really on her and the team's behalf. Y también hablamos español. So don't be afraid to contact us. Thanks so much for your attention.
Thank you, Greg. Thank you, Greg. As someone who has done manual bathroom checks many a time, I have a lot of thoughts and ideas about this. It's really cool. Okay, so we have about a little under 15 for some questions. We'll do 3 at a time. We have many questions. Okay, there's no volunteer in here. Oh my goodness. Okay, thank you. Go, Kristin.
Thank you.
I'll do it now.
Thanks, everyone, for some really interesting talks. I just had a question, probably for Daniel, the first speaker. It's an interesting point about the pH of injections, and it kind of makes sense, doesn't it? Like, don't inject anything acidic in, or too acidic. So do you think a potential harm reduction measure might be to allow users to measure the pH of something they're going to inject and maybe provide them with some sort of buffer? I don't know if that's feasible, but it would be good if people could at least know the pH of what they're about to put in and maybe change it.
Sure. So in the UK setting, where you have basic heroin, using the smallest amount of additional acid to put it into solution was the answer, as opposed to buffering. If you use too much buffer, the heroin would fall out of solution, right? The US setting, very limited experience showed that it was acceptable to use a little bit of bicarbonate, and people would do it. So yeah, I think there's definitely some possibility here in the Xylazine era. Yeah, thank you.
My question is for you also, the first speaker. I work in a safe consumption site, and one thing we've seen in Toronto, where we've had Xylazine for a long time, and one thing that's gone along with xylazine use for us a lot is like positional asphyxia, Saturday night palsy, like all these other injuries that are occurring from people that are going unconscious into really unnatural or uncomfortable positions, but then the like emergency system in your brain that's supposed to say, wake up and move, isn't happening. And so you mentioned that part of the wound problem is oxygen perfusion. So I'm wondering if you think that these kind of positioning issues might be like causing the wounds through lack of oxygen perfusion, and if so, kind of like how much would that be a factor?
Yeah, no, I think that's a very strong possibility. We did collect stories about people who had pressure injuries, who had positional injuries, all the way to the point of muscle breakdown and renal failure, right? So that's the next paper. But I consider those injuries different than these injuries, right? Doesn't make them any less important. They're actually quite serious. They'll cause a lot of harm. But thanks for bringing that up.
Hi, I'm also from Canada, Montreal. We've had xylazine in the supply since 2022. Public Health finally made an announcement about it in 2023. Right now, though, like the xylazine has disappeared and is being replaced by medetomidine, which is also alpha-2, vasoconstrictive. I know in Toronto you guys have a lot of this as well. And my question is, are we going to see the same wounds? Because if it's the same family, we would think that logically we're going to be seeing the same kind of wounds.
So yes, I think there's a class-wide effect here, and you should see the same wounds. Although I will say, I've talked to people from Philadelphia, and they're saying now that medetomidine is taking over, they're seeing the wounds getting better. So the devil's in the detail here, and this could be a positive development. It could be some other factor that's going on. Maybe medetomidine is somehow more neutral pH-wise, you know. So don't know at this moment. Thank you.
Yeah.
I've got a friend who had a presumably xylazine wound in the roof of their mouth. So this is maybe for Kristin, maybe for Daniel. Are you seeing wounds in areas where like maybe there's some tear in the epithelial layer already? Like you mentioned eye.
Yeah, so while the most common wounds are on the extremities, and that's mostly for people who are injecting, people have also experienced wounds who smoke. So it's not like smoking totally eliminates the risk of wounds. There is still risk. It's not the same as like abscesses, for example. So yes and no. I mean, part of it is that it would be totally unethical to do human trials to be like, this is exactly how it works. So yeah, we have seen other types of wounds or wounds presenting in other ways, but most commonly they are on the arms and legs. Also, just to the previous speaker about medetomidine, I think, and correct me if I'm wrong, medetomidine I think also has respiratory implications that xylazine does not have. And so that might be another consideration for overdose response, that maybe the wounds are getting better, but it might be more complicated for overdose, because while xylazine is sedating, it's not necessarily a respiratory depressant, whereas medetomidine, I believe, has respiratory depressive effects. So, just to say.
Time for another?
Hey, Pete Clark from Georgia, USA, despite the accent. One for Chris, you mentioned the Nitazenes in the UK. Is this actually taking over heroin use now? And are people actually popping them, or are they crushing them? And if they're crushing them, is that causing additional issues?
Depends what kind of subpopulation of people you're talking about. In terms of people who are getting it within heroin, they won't know, or they will rarely know, unless there's a bit of a cluster in a particular area, and then the word gets out, and then somebody might be attracted to try and find that. So in that sense, it people may start to seek out a nitazene or nitazenes which have been added to heroin, but it's but the other things are, so in benzos, people don't know, In OxyContin, we think that people now know, because most of the people that are getting Nitazenes within OxyContin, they know that that's what it's, that's what's in it, They're going to the dark web, and actually it's better that they actually know, because when you don't know, of course, it hit you like a train. So is that, I've kind of not sure if I answered your question, actually.
So is it similar to fentanyl in the US? People don't actually know it's in the substance that they're buying, or the question was, are they actually seeking the Nitazenes? Because most people in the US now know it's fentanyl.
Yeah.
There's very little heroin available in the US. It's predominantly fentanyl.
Yeah, look, it's always better when you know what you're going for and what you're getting, And there is that argument that the worst period of time is when there's isn't it, in terms of overdoses. So it may come a time where Nitazene completely supplants heroin, and maybe other opioids as well, because we don't know what's going to happen in Afghanistan, stockpiles and all the other things, that can influence that. And if that time comes, so long as it's Nitazenes which aren't themselves potentiated with other drugs, such as the Xylazine type drugs and so on and so forth, it may be safer than actually it is at the minute, where it's a bit of a run in the gauntlet. You don't really know. But in the case of the oxycodone that's being bought off the dark web, people know it, and they know it's got a Nitazene in it.
Marin, do we have time?
We have time for 2 more. Perfect. Thank you, Katie.
Thank you. Hi, we're from Puerto Rico. We're outreach workers, and my question is for Kristin. Most of our participant supply probably has Xylazine, as one knows. We don't have too much access for Xylazine tests to run around. It is extremely validating to hear that not only, in your perspective, not only medical professionals can work on wound care, since we've been doing it since our late teens, early 20s. It's what we have, I have a question on your framework. Do you have any tips to encourage people to seek for higher care, especially when you see people every day who have extremely terrible wounds, very similar as, the pictures that were up there from the doctor?
Yeah, so that is one of the things we also struggle with the most. The one thing that had been most successful for one of the programs that I work with was that they had, basically, in part because their nurse had a personal friendship with somebody at one of the hospitals. He's like, hey, will you kind of backdoor my patients in? Will you induce them on bupe in the waiting room? Will you help me do that? So like those kinds of relationships and leveraging anything you can get to get, find that nice doctor. This particular person he was a nurse practitioner, find that person who is willing to break the rules a little bit, I guess, for you, because, if he wasn't there, a lot of the clients would be like, no, I'm not going. And unfortunately, one of the clients who they were trying to get in to see him went to the hospital, wasn't there, they wouldn't give him bupe, and then he died on hospital property of sepsis-related complications. So it's really hard. It's really hard a lot of places, but building those personal relationships, because I will say most doctors and most medical professionals, they want to help people. They just have a lot of stigma and also believe in a lot of rules that like maybe shouldn't be rules, right? Or have a lot of regulations because of their hospital. And so you need to find folks who are willing to kind of bend the rules, if not explicitly break them, to accommodate your folks as best you can, because the pain management and the withdrawal management are really key to getting folks to being willing to stay to complete their course of IV antibiotics. Because, if you get, half a course, that doesn't really actually help you, right? Do you want to add anything? Okay.
Thank you.
Yeah.
I think there was one more in that direction.
Oh.
Sorry, thank you for all the presentations, and thank you for the overdose plan, because I will hopefully use that in New Zealand. Do you have any comments on Xylazine withdrawal? So when you get admitted, you were talking about induction in hospital. Any concerns about that other part? And the third question is, are you seeing anything else used on top of Xylazine? In this era of polysubstance use, do people use Xylazine and opioids? And are you seeing any other drugs together, like part of the cocktail?
So I'll start with the last question. So cocaine is a very popular addition, partly, mostly out of common sense. People are highly tolerant to the underlying fentanyl and even the xylazine at this point. So cocaine adds a little bit more joy back into the equation, but also it's an antidote to in excessive sedation, right? As a stimulant. People also use methamphetamine. That would be even a better stimulant to get people out of the slumber. The withdrawal is a problem. It's a problem. It's a problem if you unmask it. The xylazine gets unmasked because you're treating the fentanyl, either through naloxone or through buprenorphine, right? People still have to go through the sedative withdrawal. Sedative withdrawal is challenging. So I know this protocol is coming out. I'm not an expert in them yet, but I know at least the emergency departments are figuring out how to do this humanely and appropriately. So that's all I can say. Did you want to add something?
I agree with everything Dan said. And also, some of the hospitals in Maryland have been using basically benzo withdrawal treatment protocols and applying that to xylazine, which helps. But like, if somebody is chemically dependent on multiple substances, you really need to treat all of the withdrawals because they're going to feel terrible, and feeling terrible is why they want to go home, right? And so that's one of the ways. But benzo withdrawal sucks too. So it solves part of a problem, I guess.
Okay, that is our time, but they're going to be here. Are you guys available to hang out a little bit? Yeah. Okay, they'll hang out a little bit for any other questions. Thank you so much. This was an amazing panel. Thanks for staying late with us. We appreciate it. Happy birthday, Chris.